My talk now is to discuss the implant techniques, so how to do it. So looking at the survey earlier on, there is obviously already quite a lot of expertise in the room in terms of how to do implantation. We all have slightly different techniques and adapted for pacemaker implantation. So this is not saying you must do it this way, but I'm going to give you an overview of the sort of current techniques for pacing, hip bundle pacing. These are my conflicts of interest. I'm going to give a little bit of an overview on the setup, implant tools, and the implant technique. So first of all, when we're thinking about patient preparation, there are a few considerations that are specific to hip bundle pacing. The first one really is that it's very, very helpful to have a 12-lead ECG and to be able to display it in the lab, ideally with the signal from the lead. Displayed on the same channel makes life much easier. We want to be able to see the morphology of the baseline QRS and be able to see the response to pacing. And so it's very, very helpful if you have a system, and if you're lucky enough to have the EP system in the lab, it makes your life very much easier. Really, a very helpful thing to do also is to have a system for jumping the cables between the stimulator and the EP system, so it avoids you having to switch your connections around. And also when you're doing your pacing response, it's nice to be able to have the signal from the lead as well, so you can very easily see whether you have selective or non-selective capture. And there are different ways of splitting the signal. We just have a jump cable system, and then that way you have the signal going to your PSA and also to the EP system. But of course you can use the PSA directly, and there's plenty of people in this room here who do lots of implants with the PSA only. Useful to use the atrial channel, and you just think about your gain settings, so 0.04 millivolts is helpful. And I mean, I don't use this very often, but it's apparently very helpful to do, to print out sometimes if you want to see your HIS signal clearly. But again, very useful to have your 12-lead ECG, so some form of way of being able to demonstrate the 12-lead ECG. And then you want to think about, do you want backup pacing? Now, of course, when we're mapping near the conduction system, there's the risk that we're going to bump. If somebody's got left bundle branch block, we may bump the right bundle and cause complete heart block. So you want to keep your stress levels nice and low. If the patient's got complete heart block and an escape rhythm, again, I would suggest putting in a temporary backup lead so that if you do bump the conduction system where this escape rhythm's coming away, then you can just pace from the lead. And what I tend to do is just put the atrial lead into the right ventricle temporarily whilst we're doing the pacing. The thing we're trying to do is with hip bundle pacing is to target the hip bundle itself, and a lot of the procedure we use obviously X-ray, although Francesco doesn't need X-ray at all, but we need to see signal and a nice HIS signal and X-ray to give us a general idea that we're in the right territory if you want to use X-ray. Gradually, this space is developing. By still far and away, the most commonly used tools are the Medtronic tools, and the C315 was a big innovation, and this is still the workhorse of implants. We'll see when the new C304 deflectable sheath with HIS sheath comes in, how the workflow changes. But they're still by far and away the most commonly used leads. And then we've the Select Secure lead. So it's a 4.1 French lead, and it's got a fixed helix screw, no lumen. So you need to use a delivery sheath to get it into place. And also when you're deploying the lead, you turn the whole lead body. Comes in 2 different lengths, and depending on operator preference, you choose which ones. If you want to have a little bit of slack at the end, which helps with slitting, then use a longer lead. Some operators prefer the shorter lead in terms of being able to turn the lead more easily. And it's an IS1 connector. The useful thing about it is that the helix is actually an active component, so it's an active helix. So you screw into the HIS bundle and you pace directly from the helix. The lead's been around a long time and not just used for HIS bundle pacing, and it has pretty good reliability. So the delivery sheath, so this at the moment still is the workhorse, the C315, and it's got these two curves. It's got the primary and secondary curve, and the primary curve delivers you to the level of the tricuspid annulus, and then we have this secondary curve, which is very important, means that you deploy your lead perpendicular to the septum, and I think this is really a key component of the implant technique in terms of making sure it's well fixated, but also that you get nicely into the His bundle, and it's important for making sure we have nice low thresholds. If that fails, currently in Europe, it's the C304 delivery system is the active sheath. The next thing to do is to prepare the delivery system, and you can deliver this over a standard 035J wire. So when it comes to lead implantation, you can use whatever access that your preference is. I like to have two separate punctures. I tend to use axillary vein access, but there's lots of people implant it via the cephalic, and but it's sometimes nice just to have a separate entry into the vein. You don't need to use the sheath. You can put it directly over the guide wire. Again, I like to have a 7 French sheath in situ. And then just, of course, we need to just bear in mind the anatomy of the His bundle and the course of the His bundle, and potentially where we're targeting it. It depends a little bit on the anatomy, whether you're going to target it more proximally or more distally, and it depends on the underlying problem. So if someone has left bundle branch block, often more distal. If they've got complete heart block, again, you need to make sure you're distal to the level of block. So often you'll tend to be a bit more towards the ventricular side. Those electrophysiologists amongst us are all very used to thinking where the His bundle is, and in the normal anatomy patient, I don't recommend routinely using catheters from the mapping catheters from the groin, but it's just useful to have in your mind where the typical His bundle region is, and typically it's up from the CS, it's higher from the CS, and then just onto the right side of the spine typically. But as I'll go on to discuss, there is some variability. So the first thing you then want to do is deliver your sheath to the region, and as you do that normally just over the guide wire, so as you advance the sheath using your guide wire, you then withdraw the stylets, and just a little bit of clockwise rotation will bring you towards the His region. And in the patient with a normal sort of anatomy, normal heart, very often this will land you on the His bundle itself. Without really too much difficulty. The key component is mapping, and we map in unipolar. So you want to clip the red thing to the pocket. I'll use a retractor just to clip it, and then you'll get a His signal before the lead exits the sheath itself. So as you approach the tip, you'll already begin to see your signals, and you can manipulate your catheter before you even take your lead out if you want. And the basic movements essentially are clockwise rotation points the sheath towards the superior AV septum and towards the right ventricular region. Anti-clockwise rotation will bring the lead back towards the mid-posterior septum. And they're the two sort of movements that you use with the sheath. And then what are we targeting? Well, of course, we want to get a His signal, and that's the key thing. But the relationship between the atrial and the ventricular signal is important. It'd be really very important to make sure that the V signal is bigger than the A. We always talk about at least a 3-to-1 relationship between the V signal to the A signal. The problem is if you have a big A signal, you might have a big A signal, big His signal, but that you will potentially run into difficulties with atrial capture and also the sensing problems. So you may undersense the V as well. So really this big V is key. And there's just a few examples here. So here's a patient who, there we go, it's a slight delay on the, so patient with left bundle branch block, and you can see that we've got a His here, actually slightly injured His and a long HV interval, but the A is too big in this, and we'll capture probably A. But also here, the HV time is long, and actually ideally we want to be a bit more distal anyway to try and see if we can get beyond this area of conduction disease in the His bundle itself. So you see that signal, you clock, often I'll just save a fluoro image to say where that position is, so we know roughly where the His bundle region is, but then just carry on mapping. So don't necessarily take the first His signal that you see. The other thing to think about is if you go a little bit too far, then you may well get a nice sharp signal, but if you want to measure the timing of the signal to the onset of the QRS, and if it's relatively short, then it's more likely to be a right bundle potential, so you've just gone a little bit too far, so then you want to anti-clockwise and come back towards the atrium. So the typical HV time will be about 40 milliseconds or so. So that's another thing to avoid. So once you're in position, you've got a nice big V, a His signal, small a, then you're ready to fixate the lead. So really, it's very helpful to try and get your sheath advanced enough to give you good support. So you may have been mapping with the lead out a little bit, but when it comes to fixating the lead, if you can, you really want to bring the sheath up to give that support, to make sure that you're screwing the lead in perpendicular to the septum. And the advice is 3 or 4 turns. I have to say I regularly do more than 3 or 4 turns. And remember, not every turn is transmitted. So and it's not a race, so you want to just turn it and let that torque build up. But really important to feel that resistance as you're deploying the lead. Because if you don't feel the resistance, then you're likely not against the septum properly. And first of all, the lead will displace. And secondly, even if you do sort of manage to deploy the lead, you're likely, and the lead doesn't displace, you're likely not to get great thresholds. So really that feeling, that feedback from the lead as you turn the lead is really key. And you feel the buildup of the torque. Often you'll see the sheath ride back a little bit as you deploying the lead. Again, that's showing it and you're in contact nicely. You can turn the lead, and really the methods for doing that is you'll all do out your own ways of doing it, but really one hand on the sheath is what I do, and then I'll turn the lead and hold it with my left finger, turn again, so that you're allowing that torque to transmit. After you've done your turns and you've held it there, you should see the lead just turn back a little bit. Again, that's a good sign that you've been fixated into the septum itself. And you will also potentially, if you were to screen while you're doing it, you may see the sheath just ride back a little bit as you're turning the lead. So before I test, I will generally bring the sheath back. No point in doing lots of testing and then actually finding that the lead displaces. So to bring the lead back, you want to, it's a sort of push and pull. So you will pull back with the sheath and just push the lead forward a little bit. So you don't want it to sort of stretch and pull back. You want to push the lead forward so that you've got nice slack going forward. And then you go on to do your testing. One of the things to look for is to see if there's a His bundle injury current, and it's a useful thing to know. Pugal showed very nicely in his paper that's associated with lower thresholds. And again, if you see a His bundle injury current and your threshold's a little bit high, you know it's worth waiting, because very often the thresholds will come down. So it's certainly worth looking for the injury current. You won't always see it, and it doesn't mean you're not going to get a good capture, but it's definitely worth looking for. And we've got several talks on the various pacing responses, so I'm not going to discuss that in this talk. Then it comes to slitting the sheath. I use the adjustable slitter, but if you have a different preference, you may want to use something different. But the advice is to use the adjustable slitter, and you slit this in very much the same way as you slit any sheath. But one thing to think about and to remember is that it's a small lead, and if anything, it's better to have more slack, because it can be difficult to add extra slack because there's no stylet in the lead. So rather have more slack and then pull back after you've slit the sheath, rather than trying to add extra slack. Although if you need to, it's often possible. But that's just one thing to bear in mind. If you need to reposition the lead, fairly straightforward. I mean, I would just advise you bring the sheath back forwards because you want to keep that sheath in the region because you know you're pretty close to the His, and then just counterclockwise rotation. And then when you've done that, I'd recommend taking the lead out of the sheath, keep the sheath in place, and then just look at the helix, because you want to make sure the helix is completely clear of any materials, because otherwise it may be an issue in terms of redeploying the lead. So what happens if you can't locate the His? So I've said often in the normal anatomy you'll be very quickly in the His region, but things do vary, and the first thing to do is, particularly in heart failure patients, we find that the His is often very displaced. So if the ventricle's enlarged, you'll find that the His is often much lower, and sometimes also displaced more towards the right. So the first thing to do if you can't find the His is mapping, essentially. Keep mapping, but think of different locations, not just a typical place. And usually I'll go lower. And I'll often use the lead to map, essentially. So I'll pull the sheath back a little bit and then just advance the lead and basically just looking for the His signal. And then as soon as I see the His signal, I'll store that fluoro. And then you know where the region is, and then you can advance the sheath and do the fine-tuning of the lead. So, so just think, if you can't find the His, look at other locations first. And some people will use a mapping catheter. You can do a mapping. You can use a deflectable quad from above if it's very difficult. But first of all, think of different locations. If you still can't locate the His, well, one of the problems might be if it's a patient's got complete heart block, there may not be a His signal present, potentially. So you need to think of alternative things to do. And then this is an example of a patient where obviously the patient's got complete heart block, and we were not sure whether this little notch here after the atrial lead was a His signal or not. But what you can do is you can do pace mapping. So even before you deploy the lead, you just go high output pacing, and you look at the response, and you see in this patient here, we got a beautiful narrow QRS, and very typical. This was non-selective His capture. So pace mapping can be very useful, particularly in patients with complete heart block. So very easy to do. Unipolar doesn't really cause much issue. And then when you're in the right position, you deploy the lead and then look for all the things. So pace mapping is a good thing to think about. So difficulties in locating you. So we discussed some of the things. The other thing then to think is if you're having difficulty with sort of the cranial caudal location, this is where the deflectable sheath can come in and be very helpful. So you may have located the His, but just you're always approaching it from lower down, so you may switch to the C304 sheath. The other thing is you may well want to, you may have a bit of difficulty with reach. So the C315 curve sometimes just doesn't seem to be long enough. And one of the things you can do is you can get your His lead there, and you may do 1 or 2 turns. Because the problem is you can sit on the His, and every time you advance the sheath, it may displace the His lead. So you might do 1 or 2 turns, just to sort of slightly attach the lead, and then bring your sheath over and do further turns. And we're looking forward to seeing the new deflectable sheath, because that might be helpful. And I just thought I'd finish with a couple of patients. So this was a patient we did on Tuesday, patient with DCM, left bundle branch block, and he'd referred from a different hospital because they'd had a failed LV lead implant. They just couldn't get into the coronary sinus. So we mapped the left bundle branch block. This is the first position. So we got this signal here. Not the most impressive His signal, but I thought, well, let's just pace here to see if we're in the right region or not. There's this little notching here. Is this the His bundle? And we did capture. We managed to capture the His bundle, but clearly we hadn't corrected the left bundle branch block. So we know we're in the right region, but we probably want to be a bit more distal to that position. So I didn't deploy there. But then mapped a little bit further, went slightly more distal, and we got this signal here. So you can see this is a much more impressive looking His signal. So we decided to deploy the lead in this position. And then when we paced, we very nicely corrected the left bundle branch block. The trouble was the threshold was 2.5 for correction. And then when we went down and got to below that, we we still captured the His bundle, but we didn't correct. So we had left bundle branch block pattern at 1 volt. So, so the question is, what would you do next? So we can actually vote here if you want to make it all interactive and things. So first of all, would you just accept that position, maybe wait a bit longer, see if the threshold came down? Would you reposition the lead straight away? Would you think about a 2-lead approach or try and reattempt the LV lead implantation? Good, okay. Yeah, I mean, that would have been one of the things you could definitely do. I mean, we did wait a few minutes, a little while to see. It's, as you say, it's a very, very nice response in terms of the QRS was shortened. The nice thing about this is you're not giving up the position. So if it turns out that, so the problem if you undeploy the lead and then redeploy, and you might not get something that's as good as what you had. So using a 2-lead approach, you have the original lead, which is the one on the lower. You have that there in hand. So if it proves to be difficult, then you can always go back and use that one with a slightly higher threshold. But then with the lead being in place, you can actually map. You can map just distal to that, and it gives you a nice marker to allow you to decide where to put the lead. And that's what we did in this case. And if you look at the trace, which is at the bottom, I'm sorry, but the His signal is not quite as nice. But we know that we're close to the His bundle, and we know just a little bit more distal. So we deployed the lead there, and then we can see we got this, again, very nicely corrected the left bundle branch block, and the threshold was much better here. So we were able to accept that. So it was definitely worth doing in this case in terms of the thresholds. And then just one more example. Again, this is a patient we did on Monday. So a patient who'd had a recent STEMI, had a temporary wire put in over the weekend on the Sunday. I came in on Monday morning, came to the lab. Turns out, actually, his ejection fraction was 40%. So he didn't quite meet the criteria for an ICD, but we said, right, it's not going to be good for him to pace his RV all the time. So we can see we mapped, and we saw nicely atrial signal with a hiss, and then block. So there was so it gave us an idea that we're in the right territory. We actually we moved it on a little bit further there, and then we deployed the lead. And you can see here quite an interesting, what probably looks like a split hiss signal at the bottom. I'm sorry, it's sort of at the bottom of the slide, but there's the here and here, the two hiss signals. And then we paced, and actually we got a very nice QRS. So clearly we were managing to capture the conduction system below the level of block. But the threshold here was 2.5. And for Brady pacing, this patient is going to be pace independent. For Brady pacing, I really like my threshold to be, acute threshold to be less than 1.5. Ideally less than 1, but definitely less than 1.5. So I didn't want to accept the 2.5, although the QRS was really nice. So again, there's to be a series of options. What would you do in these patients? And there's different things you could try. You could try pacing a bit more distal. But the key message, I know Francesco has shown us some of this data, which is not just our data. This is a European experience from many of the faculty here. It includes. And there is a learning curve. 30 to 40 leads, your fluoro time will come down. But also your capture thresholds will come down. And that's partly because you don't necessarily accept the first position. So it's having that confidence to say, right, we're on the His bundle, and but actually I'm not so happy with the threshold, and having the confidence to say, I'm going to go on and try and get a better threshold. Make sure that my contact is good and I'm actually engaging in the His bundle and to the conduction system itself. So that is important, and success rates increase with experience. So don't be put off if you've done 10 cases and you say some of them, sometimes it's difficult. There is a learning curve. There's a learning curve when we all learned to put in LV leads, and it's the same with his pacing. So I'll finish there.